We will allow time for questions through the webinar's chat feature at the conclusion of the presentation. If you have questions during or after the presentation, please enter your questions into the chat feature of the webinar. At this time, I'd like to turn things over to Erin Long from the Administration on Aging, Administration for Community Living to provide a brief welcome.
Hi, everyone. My name is Erin Long. I am the Program Officer responsible for ACL AOA's Alzheimer's disease and dementia programs. I want to thank you for taking the time out of your schedule to attend the webinar. We very much look forward to hearing what Rohini is going to tell us on about the 2015 update of the national plan. I would also like to ask that if anybody has any feedback from our webinar series today, if they should let you know, you should feel free to contact me. My email address is erin, ERIN.long, L-O-N-G, @acl.hhs.gov. Again, thank you so much, and we will, I'll turn it back to Sari.
Thanks, Erin. Today we are going to hear from Rohini Khillan. Ms. Khillan is an analyst in the Office of the Assistant Secretary for Planning and Evaluation and the Federal Staff Lead for the Advisory Council on Alzheimer's Research, Care, and Services and the National Alzheimer's Project Act. She is the point person for the work of the Advisory Council and manages the Council's activities and coordination on the national plan to address Alzheimer's disease. She also works on related issues including dementia care models, long-term care, and long-term care financing options. We welcome and thank Rohini for her presentation today. I'll turn it over to you.
Great. Thanks, Sari, and thanks, Erin, and welcome everybody, and thanks for being here. So I'm just going to provide today a brief update on the 2015 update to the national plan, which hasn't been released yet, which I will get into a little bit later about why, but we expect it shortly. And I'm going to just start with a brief overview about NAPA, the Act itself, and then get into more detail about the plan as we go on. So just some key features of the National Alzheimer's Project Act, or NAPA, and I'm sure many of you know this already, but it was signed in 2011 by the President, and it requires the Secretary to establish the National Alzheimer's Project, which involves the things listed here, and that it was an attempt basically to sort of coordinate everything that's going on in the federal government around Alzheimer's disease and dementia. So it was also an attempt to get everybody in the federal government to talk to each other about what they're doing on dementia and maybe coordinate those things better, and with the intention of improving earlier diagnosis and coordination of care, treatment, and the coordination of services. And part of this was also to create an advisory council that would review and comment on the national plan. So just a bit about the advisory council itself. So there are at least 22 members, and it meets quarterly. Our next meeting is actually July 27th. And we have a chairperson and 12 members of the public, which represent different groups of stakeholders. And then we have at least 10 representatives from federal agencies. So you can see them listed there. And the 13 non-federal members of the public are represented by these groups. So we have one member who has Alzheimer's disease, that's Dennis Moore currently. And then we have 2 caregivers, 2 providers, 2 state and local government officials, 2 researchers, 2 voluntary health association representatives. And then on the other side, we have representation from all over the federal government, mostly HHS, but we have actually started branching out to the Department of Labor and the Department of Justice, especially as we go into issues around elder justice and elder abuse. So now just a little bit about the national plan. So the first national plan was released by Secretary Sebelius at NIH in 2012, and it's most important point on this page is that we really want it to be a national plan and not a federal plan. So we are branching out over time and trying to incorporate more of what the private sector is doing, so it's not just a list of what the government has done. That is something we need to work on, but it is improving. And there are 5 long-term goals, which are then divided into strategies and then immediate action steps, excuse me. And every year we are required by law to put out an update to the national plan. And this year's update, due to a change in the clearance process in HHS, is taking a bit longer to release. But it was completed at the end of April internally, and we're hoping it will be released hopefully by the end of this month. So the National Plan and Practice, so it's a compendium of these completed and ongoing activities of the federal government at this point, and someday hopefully more of what the private sector is doing. And it is a list of what's being done by the government, what has started happening to address needs of people with dementia, cross-agency collaborations, and many of the activities are based off of recommendations from the Advisory Council, but we also have activities that come through work across the country by relevant agencies, such as grant programs or innovation grants and other collaborations with private sector groups. So these are the 5 goals of the national plan. The first is to prevent and effectively treat Alzheimer's disease by 2025, and it's just important to note that when we refer to Alzheimer's disease throughout the plan, it refers to Alzheimer's disease and related dementias. We have to keep using Alzheimer's disease because when the legislation was passed, it was passed with the word Alzheimer's disease, and it will require an act of Congress to get that changed. So that's why it's sort of throughout the plan and throughout all of our websites and everything, we keep referring to it as Alzheimer's disease, but it refers to dementia generally. So the second goal is to optimize care quality and efficiency, which involves things like building a workforce to provide high quality care, ensuring timely and accurate diagnoses, educating the patients and families about their diagnosis, exploring new models for care, care transitions, coordinated and integrated health, long-term care, and improving care for populations that are disproportionately affected by dementia. Goal 3 is to expand supports for people with Alzheimer's disease and their families. So that is culturally sensitive education, training and support, family caregiver support, and maintaining caregiver health and well-being, assisting families with planning for future care, and maintaining the dignity, safety, and rights of people with Alzheimer's disease. Goal 4 is to enhance public awareness. So that is awareness campaigns, working with state, tribal, and local governments to improve coordination, and to also coordinate globally with global partners who are also working on this disease. And then finally, goal 5 is to continue to track our progress and monitor the progress as we continue with the national plan. So even though it hasn't come out yet, just a bit about the 2015 plan update. We have tried a new format this year. The old version of the plan was sort of this very long list of well, I'll get into that in a bit, but it's a narrative format this time rather than the list. We have a more detailed look at the activity level. It's still available, but we don't have sort of the listed out version that it was before. We have more reference to related dementias and or dementia generally, as I said, because we want the focus of the plan to be beyond just Alzheimer's, excuse me. We are also working more on collaborating between federal partners. So as I said, we've added some more activities that DOJ is doing, for example, and others in there. We also worked with the Office of Civil Rights this year on some things, so we've added that in as well. And we've kept it to sort of relevant updates or completed items in order to sort of shorten it and make it a little easier to look at. So again, more about the new format. So we received an awful lot of feedback from many, many people that the way the plan was previously was very hard to sort of understand. And we recognize that ourselves, because every time we added an activity, the plan would just it would just keep increasing and increasing and increasing, and it's sort of this never-ending list. It used to be all the activities listed out and described, and then there would be a marker next to it that said they were either complete or ongoing or nothing. So now, just to make it more of a progress report, we've only stated the ones which are complete and their results, or ones that have relevant results that are worth sharing from 2014. So we've sort of combined a few sections from the old plan, but it's still organized by goals and strategies, and we still include the completed reports. So this is just an example of sort of what it looks like now. So you see it's still by strategy, strategy 2.A, and then we have, we have this one thing that this person-centered counseling training program, this one activity that was completed, or in this case, achieved results within 2014 that were worth sharing, and we wanted to share that. So that was reported on. So just as another heads up, we are planning to do some more changes over the summer. I'm working on this with some federal colleagues and with the HHS strategic planning team. So they handle the entire strategic plan for the department. And there is this implementations milestones appendix, which is literally an Excel file that's 22 pages long of all the activities in the plan. And we have an awful lot of activities, some which are completed, some which are ongoing, and some which have no status whatsoever at this point. So we're going to try to clean that up. And then if something has been completed, what is the next step? How do we follow up? Can activities be consolidated? If something is not complete, when can we expect it to be completed? And is there some sort of timeline, or can we, break it up so that something will be completed soon and the rest of it won't? And then we also want to make it more of a national plan rather than a federal plan. So we have to look into how we can best start coordinating with our private sector colleagues. So next I'm just going to share some of the completed projects under each goal, which will be in the 2015 update. I know that this presentation, is about care and services, so I'm just going to quickly run through the ones under Goal 1, which are research-based. But these are some of the advances that were enabled by the additional funding that NIH received in 2014. There was an increase of $100 million in FY 2014 and $25 million in FY 2015. So to NIH in order to follow up on some of these things. And so they're listed there, and if anyone has questions or wants more details, I'm happy to share them. So under Goal 2, we have the GECs and professional education. So HRSA's 45 geriatric education centers, which are the GECs. We're able to partner with 719 community stakeholders to provide almost 1,500 interprofessional educational offerings to 160,000 health professionals on dementia. So in 2014, HRSA was able to expand this GEC program even further. And next we have the Healthy Brain Initiative from CDC, which is continuing on, and they've just published the Healthy Brain Initiative Public Health Roadmap for State and National Partnerships, which is their work from 2013 to 2018. and this is part of the Healthy People 2020 and part of their objectives for the dementia portion of the Healthy People 2020 initiative. Then there is PFEC, which is the Patient and Family Engagement Campaign. This was concluded in 2014, and the main goals were to involve beneficiaries and families in decisions regarding health and healthcare, and propose projects, targeted behaviors among beneficiaries, families, and providers, including among them care for individuals diagnosed with dementia. So they have recently published these the results from this campaign, and they have materials that they can share with families around the country. Another, the Geriatric Workforce Enhancement Program, also from HRSA, which was brand new, and they may actually have results to share later in July, but they introduced this program, and it allows geriatricians to develop programs that are responsive to their needs and to the needs of their community. So you can develop your own training program that would help your particular community. NQF had this great project that I'm sure a lot of you have already read and possibly commented on, but it was priority setting for healthcare performance measurement. So it was a way to develop quality standards for Alzheimer's care. And it was a really great report, and they identified a total of 60 measures in the United States and 65 measures internationally, and so now they are working to create guidelines from these quality measures that they've found. And then finally, we concluded the IOM expert panels on advanced dementia. We started in January 2014. We had 3 panels. In January 2014 was research. In September of 2014, we did innovative care models. And then in January of 2015, we finally had policy recommendations from this panel. And those recommendations were shared with the advisory council and were taken into consideration for the plan. So goal 3, these are a few. I feel like I'm, sorry, I lost my paper. Okay, so in goal 3, so we have the National Alzheimer's Call Center, which is through ACL, and it is available at all times every day to people around the country to provide expert advice and care consultation to people with dementia and for their families. Then we have AFB recently released adult daycare and residential care policy compendias, and this was a compendia of regulations around adult day services around the country, and the second compendia was on state approaches to residential care, and we are also going to be releasing a look at dementia care units within residential care and the effects on quality of life eventually. We're still working on that. We had, let's see. We had a survey at ASBE, which was to examine attitudes around long-term care. The survey looked at it was a large sample of about 16,000 people between the ages of 40 and 70 to see if they understood long-term care, if they understood the terminology, and basically if they understood insurance first of all and then long-term care insurance after that. And it was just to sort of get everyone's opinions on long-term care financing options that are being developed all over the place. And the second part of the survey was interesting. It was a discrete choice experiment, which involved a choice of long-term care insurance policies with different features and different prices. And people were able to sort of pick and choose what they liked and what they didn't like, and we were able to determine from that what the ideal long-term care option would be. Then we had a contract with the National Quality Forum to do an environmental scan on, let's see. Oh, I'm sorry, I apologize. We had the National Partnership to Improve Dementia Care in Nursing Homes, which continues to improve nursing home care across the country. And in September of 2014, the National Partnership, through a public-private coalition, they established a new national goal of reducing the use of antipsychotic medications in long-stay nursing home residents by 25% by the end of 2015 and 30% by the end of 2016. And you may have all heard of the GAO report on antipsychotic use, and we are looking into that. They suggested that it not only be applied in nursing home, but a reduction in antipsychotic use be applied in outside of the nursing home setting, so in home and community-based settings and residential care. And finally, we have the work that we did with the Office of Civil Rights in order to try to develop a HIPAA privacy rule around Alzheimer's disease and related dementias. The resource list doesn't specifically address dementia. We modeled it after one that was created for mental health, but the Office of Civil Rights was a little uncomfortable creating one for every single disease. So what it does do, however, is it provides links to materials that would be relevant to providers who are helping families and individuals with dementia, and this document continues to be refined, but we do have at least a first version to go with. I just wanted to talk a little bit about ADI and ADSSP updates in the plan. So the ADI-SSS grantees and their partners, there are 10 of them located across the country and in Puerto Rico. The grantees are operating within dementia-capable systems and implementing new programs designed to provide more effective services to individuals living alone in the community with dementia, individuals with intellectual disabilities who have or are at risk of developing dementia, and caregivers who need behavioral symptom management training. And one of the aims of the behavioral symptom management effort is to reduce the use of antipsychotics in home and community settings, as was called for in that GAO report. And ACL intends to fund 10 new dementia-capable states or other entities in 2015 to implement new programs in these 3 areas and possibly others. And in addition, ACL plans to develop public-private partnerships to promote dementia-friendly communities to the extent feasible. The focus on people with intellectual disabilities and fostering of dementia-friendly communities is in direct response to recommendations from the Advisory Council. On the ADSSP side, ACL continues to support its 15 current grantees and their partners who are implementing dementia-capable LTSS systems, and any former grantees or partners who wish to participate in learning activities. The grantees have led dementia agencies in direct response to recommendations from the Advisory Council, and grantees are developing a no wrong door service system, ensuring access to comprehensive, sustainable services for people with dementia and their families, and implementing evidence-based interventions as part of their program. Then we have ADI-SSS grants in the state of Minnesota, which are planning stage for developing 4 dementia-capable cultural communities. The Hmong, Somali, Hispanic, and African American communities. These dementia-capable communities will include community education and training. Then both the ADI and ADSSP program grantees are implementing evidence-based, evidence-informed interventions for caregivers, including resources for enhancing Alzheimer's caregivers' health, which is the REACH intervention, Savvy Caregiver, BRI care consultations, NYUCI, and STAR-C. Additionally, 12 states continue to offer ADSSP funded interventions beyond their federal funding period. And in terms of outreach activities, all of the ADI and ADSSP grantees are engaging in outreach activities, and there is no one structured program outside the work of the educational opportunities provided by the National Alzheimer's and Dementia Resource Center that you are all participating in now, but these webinars continue, and we are. So for goal